Hello and good afternoon, everybody. Together with my friend and colleague and partner, Alessandro Repici, we welcome you to this event this afternoon. Both of us founded Endoscopy on Air more than 2 years ago. And we did some very large live streams in the field of gastrointestinal endoscopy. The last one was held at the beginning of June this year with more than 50,000 viewers worldwide. So it's only logical that there is some desire to expand the field to go to other areas. And we are particularly happy that this is the first event in pulmonology, in bronchoscopy. And we welcome you all on behalf of Endoscopy on Air. We are glad to welcome the speakers, Professor Trisolini and Professor Sivokosov. And also we welcome the sponsor of this event, Medi-Globe, Martin Lehner and Martin Kropf. Medi-Globe actually in gastroenterology, as far as I remember, years back was the first company to develop an EOS-guided puncture needle. And so welcome everybody, welcome speakers. On behalf of Alessandro Repici, who I think soon enters a plane in southern Italy, we wish you.
Here. Thomas,
here you are. You are in the fourth space. Hi, Ale.
Ciao, Thomas. Welcome everybody. It's such a great pleasure. I can just echo Thomas' word, and we're so happy to have Pulmonology on Air, this new venture. We do believe that bronchoscopy is a great field where we can work with all of you, developing a new initiative, a new platform for education. We're so glad that the two chairmen accepted to guide us in this first meeting, and also very grateful for sponsorship to Medi-Globe. So we want to wish all of you best of luck for this event, and we will come back to all of you soon because there will be more events to come. Thanks for joining us. You are so many. This was really unexpected. Brilliant, all of you. Bye.
Yeah, thank you very much for that kind introduction, Professor Resch and Mr. Repici. And good afternoon, ladies and gentlemen, and a warm welcome to all participants around the globe here from Germany, and specifically more from beautiful Bavaria. My name is Martin Lehner, and I'm the CEO of the Medi-Globe Group. And of course, we are very excited today to co-host this event together with Pulmonology on Air. To my background, I have over 15 years of experience in various healthcare leadership positions. My focus areas have been oncology, cardiology, and most recently gastroenterology, as well as pulmonology. Before we enter the masterclass session today, I would like to give you a short snapshot about Medi-Globe Group, the product and the products that we are using today in the demonstrations. First and foremost, Medi-Globe Group is specialized in single-use devices for minimal invasive endoscopy procedures for urology, gastroenterology, and pulmonology. Medi-Globe engineers its products and technologies 100% in Germany, and we manufacture them in our state-of-the-art factory right here in Europe, which has been a major asset throughout the recent most challenging times. We employ around 670 people worldwide and have our own subsidiaries in Germany, Austria, France, Brazil, Czech Republic, as well as in Hong Kong. Beyond that, our products can be found over 120 countries worldwide. Next page, please. Our dedication to build the highest quality needle technology started, as you mentioned already, more than 30 years ago, when Medi-Globe introduced, together with Professor Peter Fielmann, a new groundbreaking needle for EOS procedures. Ever since then, we've been dedicated to develop our products together with clinical experts to improve safety, efficiency, and handling. By the mid-90s, Medi-Globe was already fully focused on single-use devices and on minimal invasive surgery. In 2006, we introduced the Ebus FNA under the Sonotop under Sonotip Pro and Sonotip ProFlex brands. In 2019, another milestone was the launch of the fine needle biopsy FNB Sonotip Topgate. Most recently, we launched the only 22G needle for EUS. Following our heritage, we are currently designing and developing with dedicated users around the globe the next generation of needles. This being said, I would like to introduce a colleague of mine. This is Martin Kropp, the International Sales Manager of Medi-Globe. Martin brings over 22 years of experience in single-use endoscopy devices to the table, and he has been participating in endoscopy surgeries and user discussions around the globe. Martin.
Yeah, first of all, hello everyone. Good morning, good afternoon, a warm welcome to all participants around the world. Yeah, thank you, Martin, and thank you, Medi-Globe, to organize and finally realize this Ebus Masterclass. I'm very excited. We just learned we have more than 2,300 participants around the globe. And therefore, I'm very proud today to be your moderator, and I hope I will manage doing it well. And also the technical and transmission will work fine. But first of all, I really like to address a special thanks to Professor Repici, the Endoscopy on Air team, and both Medi-Globe and Endoscopy on Air touching with this event breaking ground. And the amount of participants are showing the interest of it. But before we are going to start, I would like to share quickly some information about our needle portfolio. Medi-Globe is offering a wide range of needles, not just for Ebas. We have EOS needles as well as needles for endoscopic procedures. Providing such needles as nitinol, stainless steel, FNA, and our brand new recently launched FNB needles for histology examination. And specific laser cut on the end of the needle will ensure maximum visibility and control. And last but not least, the twist lock technology, which helps to optimize and control the handling. I would say that's enough from Medi-Globe. Let's move to the event and let's start the Ebus Masterclass. I would like to share upfront some information with you. During the lectures, we will have some live posts from time to time, live polls from time to time, and it would be nice to have your active participation and learning from your experience. But let's start with the first one. Heike, can you display the first poll, please? Thank you very much. We would like to know what is your expectation for the Ebus Masterclass today. We have best practice sharing, live cases. I would say let's have 1 minute to fill that out and see what the participants vote for. Give us your feedback. Be encouraged to participate, please. And I would love to hear and see your opinions. Let's wait another 20 seconds. It looks like best practice sharing. Learn more about Ebus FNB. It's clearly dominating. Live cases, interesting. Learn more about Ebus FNB. Let's have another 10 seconds here. I'm really looking forward to get your votes. Still best practice sharing, learning about equal. Exchange with the speakers, also very important. Use the chance today, the chat function. Thank you, you have closed the poll. I would say it's equal, best practice sharing and learn more about Ebus FNB. Thank you, Heike. So I can move forward with my presentation. Do you switch off this window, please?
You have to do it by your own.
Okay, result. I have to release the results, right? Okay. So clear what I said, best practice sharing and learn more about US FNB. That's the winner here. Yeah, let's see what comes and let's look for the interesting lectures here today. So I need to stop that here, right? Okay, good. Let's move to the next slide. Yeah, just brief a look into today's agenda. Our speakers are Professor Rocco Trisolini and Dr. Ilya Sivokosov. The first part will be presented by Professor Trisolini with malignancy FNB used on the Pentax bronchoscope followed by a Q&A session, which I'm really looking forward to. And then we have the second part, which will be presented by Ilya Sivukosov. Ilya, I hope I spelled that right. Your part is granulomatous disorders, FNA, FNB. Try to do my best. And you're using Olympus bronchoscope. As well as here, we have a Q&A session and then our closing. But let me introduce more in details our speakers today. The first one, Professor Trisolini. He's chief of the famous Polyclinic University Gemelli in Rome. Professor Trisolini is a member of several societies. He's author of more than 150 scientific publications and around the globe active in research and education program. Welcome and thank you, Professor Trisolini. The second famous person today is Dr. Ilya Sivukosov. He's chief of the respiratory endoscopic department in Moscow in Russia. Dr. Sivukosov is one of the explorer of Ebus procedures in Russia, touching breaking ground in performing new techniques and procedures specific over Russia. He's the author of more than 100 scientific publications and a member of several expert communities. Since years, he's active in training and education. Welcome and thank you, Dr. Sivukosov.
Thank you so much.
Okay, let's start. I just need to stop my presentation here. With the first lecture, we will start with Professor Trisolini, and we have prepared some polls for your session. Prof, I think you will take over. And Heike, can you start with the first poll, please, here? Hope everybody can see. So do you use endosonography, Ebas or EUS in patient with suspected intrathoracic lymphoma? Prof, would you like to comment here a little bit?
Yeah, I don't see them, however.
Can you see the you cannot see the window?
No.
Okay.
I can now, yeah.
Yeah, thank you.
Yeah, the question is, I would like to know whether or not the participants use Ebus or EUS on a regular basis for intrathoracic lymphoma. In particular, I would like to know if they send the patient directly for surgery, if they use Ebus or EUS on a regular basis as a upfront option for lymphoma, or if they do this just because sometimes it is not lymphoma, but maybe sarcoidosis or lymph node metastasis from malignancy.
Yeah, people still voting. Currently, the second one is leading. Yes, because of Ebas, EUS allows to reliable diagnostic. Well, let's wait another 20 seconds. Still leading. Okay. I think we can close that. I will release the results.
This is interesting, and as you can see, there's quite a high variability. Most of the people, and I agree with them, use Ebus in the US mostly because sometimes, and I would say very often, it is not lymphoma, because diagnosing lymphoma on Ebus, as we will see, is not that easy. So this is interesting and is a good opening for my talk.
Good. Then we have a second one, Professor. Let's start with the next one.
Yeah, the second question I would like to share with you is whether or not you are satisfied on your diagnostic success for molecular profiling of lung cancer on Ebus FNA needles. And I would like to know which is the percentage of success for a complete profiling, which includes both genotyping and PD-L1 testing.
Yeah, we have the first one leading. Optimal endosonography samples are successful in 90 to 95%. And second lead is the second question, optimal for cancer genotyping. Let's wait a little bit more. Still the first one is leading with 34%. Let's see. really ask the audience to participate here and join this questions. It helps all of us, and it's very interesting. I think we have the final one, right?
Yeah, this is interesting. As you can see, once again, there is a huge variability in the success rate for the molecular profiling, which is what I learned from people working everywhere in the world. So again, what I will say, I hope will be useful for the participants.
Okay, then we can close that here. And I would say, Rocco, it's your stage. Let's start with the lecture and live.
Let me see if I can. Can you see the
yes.
I talk? Okay, perfect. Thank you very much, Martin, for your kind introduction, and a warm welcome to all the participants to this seminar today. The aims of this talk will be to show the organizational setting and the equipment that we use in our Center for Endosonography, and what is more, to share and comment with you all 3 cases of Ebus fine needle biopsy in different pathologic malignant conditions. Let's start from the organizational setting and the equipment that we use. In our center, for every interventional pulmonology diagnostic and therapeutic procedure, we use an endoscopy suite, which is certified for non-operating room anesthesia, and as you can see in this short video, as a workstation for the pathologist. Patients are deeply sedated with propofol and remifentanil. The oxygenation and, whenever necessary, the ventilation are delivered via a laryngeal mask airway, and rapid on-site evaluation is available for every procedure. When doing Ebus fine needle biopsy procedure, this is the equipment that we use. We use an Ebus EB19J10 Pentax ecobronchoscope, which is coupled with an Hitachi Aloka Arietta 850 ultrasound machine. And as needles, we use the Medi-Globe Sonotip Top Gain, which are 3-tip crown cut needles, which have been already shown in the GI field their ability to improve the retrieval of tissue cores. When I use this specific needle with this specific ecobronchoscope, I insert the needle into the operative channel with the stylet unlocked and slightly retracted. In this slide, in this short video, you will see the endoscopic and the ultrasound visualization of the needle. On the left, we are into a dilated esophagus. This is an EOS-B procedure. You can see very well the needle sheath, which is blue, so it is clearly visualized. And in the right image, we are looking for the perfect entry point into this subcarinal lymph node. You will see the penetration of the needle into the esophageal wall. And especially, you will see the perfect visualization of the needle, especially of the needle tip, which allows you to sample safely any lesion. Now that we have seen the organizational aspects and the equipment that we use for this procedure, let's move on to the clinical cases, which will have a similar outline. We will see what we know about the ability of Ebus to diagnose that specific suspected condition. Then we will move to the case by showing the history, the endosonography, and the histology findings. And then we'll comment the final diagnosis. What these cases of suspected malignancy have in common is that in many cases, the FNA needles may not be able to provide the answers that you are looking for. The first case I'd like to share with you is a case of fine needle biopsy in a patient with suspected lymphoma. This slide summarizes basically what we know about Ibustivini in the setting of lymphoma. It's 4 key info that we will develop in the next few slides. The first key thing is that the diagnostic sensitivity is significantly lower and more variable in lymphoma than in patients with epithelial malignancy. This recent meta-analysis demonstrates how the diagnostic success of Ebus in this setting is only 67%, which is much lower than what we get in the setting of epithelial malignancy. And as you can see, the variability of the diagnostic yield is significant, ranging from 30 to 90%. Importantly, the diagnostic success is strongly influenced of what you consider diagnostic. If establishing a generic diagnosis of lymphoma is your target, then you can get a diagnostic yield of 70 to 80%. But if you want to subtype the lymphoma on the Ebus FNA samples, then the diagnostic success drops by far. In this multicentric study, for instance, as you can see, the sensitivity for a generic diagnosis of lymphoma was 73%, but the sensitivity for subtyping the disease was very, very low at 24%. The few papers that we have in the literature does not show the ability of 19 gauge needles to improve the diagnostic success of Ibustivini in the setting of lymphoma. In the study, which is shown in this slide, the diagnostic success of 19 gauge needles was only 67%, which is similar to the success rate reported in the literature on average with 22 gauge needles. Ebas intranodal forceps biopsy has shown promising results in a handful of cases, and these results need to be obviously confirmed on larger series. But you have to consider that this technique is significantly more demanding technically and is more costly because it involves creating a hole in the respiratory mucosa with a needle and then using a second device, a biopsy forceps, to go through the hole and into the lymph node to do the biopsy. So basically, these slides confirm that we have a lot of room for improvement with Ebus in the setting of lymphoma. The case I'll show you is a case of a 62-year-old man, former mild smoker with a remarkable past medical history, who seeks medical attention for a dry cough and weight loss of 3 months duration. He is submitted to a chest X-ray, which shows an enlarged mediastinal shadow. And as such, is submitted to a contrast-enhanced CT of the chest, which, as you can see, shows a diffuse intrathoracic lymph node disease. The patient is sent to our center for an Ibustivini in the suspect of sarcoidosis, but when we review the images, we realize that there are a couple of things that are more suspicious for lymphoma than for sarcoidosis. And these are the involvement of anterior mediastinal lymph nodes, as highlighted by the yellow arrow, and the presence of an asymmetric hilar involvement, as shown by the red arrow. So based on our suspicion of lymphoma, we decided to start the procedure directly with the Ebus FNB needle, and we chose the station 4R, which hosted a very large lymph node. As you can see here, below the lymph node, you will see the superior vena cava, which is slightly compressed, and you will see the needle, which is clearly visualized and will do its back and forth needle aspiration maneuvers. We did, in this case, 4 needle passes with suction. The rapid on-site evaluation of the raw smears shows some very interesting findings. In the left-sided image, you will see highlighted with the red arrows 2 non-necrotizing sarcoid-like granulomas, which can be found in patients with lymphoma in more than 10% of the cases. But studying a little at higher power, the area highlighted by the green circle, you will see, besides the granuloma, which is again highlighted by the red arrow, the presence of lymphoid elements with blastic aspect, which might suggest the presence of lymphoma. And in fact, in other fields of the same slides, we were able to identify several blasts, several lymphoid blastic elements with polylobated nuclei. And this further strengthened the suspect of lymphoma. Obviously, in a case like this, you need a lot of tissue and a preserved histology to do the diagnosis. And here is the good news, because with these needles, you usually get a lot of material. As you can see, when we do a procedure with these Ebas FNB needles, we extract the material with the stylet, we put it into a slide, and then with a needle, we retrieve the tissue cores from the slide and we put them into a vial, which will then fill with formalin solution. As you are seeing, with a single needle pass, you can get more than 1 tissue core. And you have to gently take them and put them into formalin solution. The liquid material that remains in the slide is smeared again and again submitted to rapid on-site evaluation. After the 4 needle pass that we did in this specific case, we got a lot of tissue, as you can see in the formalin vial. And this is what you get. This is the examination of the tissue cores at low power. As you can see, they are highly cellular, which is very important. Going at higher power, in the left-sided image, you see a large tissue core, very cellular. And what is important is that even at the edges of the core, the morphology is very well preserved, which is very important for the pathologist. In the right-sided image, you see a large non-necrotizing granuloma, very similar to those seen in the cytology smears. At high power, in a background of relatively small T lymphocytes, you can see, highlighted by the green arrow, a lot of blastic elements which belong to B lineage as documented later on by the immunohistochemistry, and even highlighted by the yellow circle, a mitotic figure. So thanks to this material, our pathologist could diagnose the T-cell rich B-cell lymphoma, and you will see how large was the immunohistochemistry panel that the pathologist could perform on these tissue cores, which are considered optimal, both from the quantity point of view as for the quality of the material. The second case I'd like to share with you is significantly less common, and is a case of Ebus in a patient with suspect vascular sarcoma. This is quite uncommon. Pulmonary artery sarcoma are exceedingly rare and are often, at least initially, misdiagnosed for thrombotic pulmonary embolism. Until recently, the few cases assessed with Ebus have been punctured with FNA needles. But diagnosing these cases on FNA cytology might be a gamble because these cases have a very poor prognosis and the management is extremely complex as it involves, ideally, preoperative chemotherapy followed by pneumonectomy and pulmonary artery resection and reconstruction under extracorporeal circulation. The case I'll show you is a case of a 61-year-old female, never smoker, with a remarkable past medical history, who seeks medical attention for the sudden dyspnea, right chest pain, and hemoptysis. The blood gas values show an hypoxemia and an hypocapnia, so the emergency room doctor submit the patients to a chest CT angiography in the suspect of pulmonary embolism. And the test documents a complete obstruction of the right pulmonary artery and a subpleural nodular infiltrate of the superior segment of the right lower lobe. This is the CT. In the left-sided image, you clearly identify the complete obstruction of the right arm of the pulmonary artery. And in the right-sided image, you see the nodular infiltrates of the superior segment of the right lower lobe with the red arrow indicating a bronchus sign. The patient is treated with for 1 month with warfarin, which allows to obtain an improvement of symptoms and of blood gas values, but the CT remains absolutely the same. This is the reason why the patient is submitted to a PET scan, which shows an increased uptake of the right pulmonary artery obstruction and the peripheral pulmonary lesion. The case is then brought into a multidisciplinary team discussion, which reaches the following conclusion. The patient has a suspect sarcoma of the right pulmonary artery. The thoracic and cardiac surgeons are willing to consider surgery, but they require a preoperative confirmation of the diagnosis of sarcoma and the exclusion of malignancy for the right peripheral pulmonary lesion. For this reason, we decide to perform an advanced diagnostic bronchoscopy procedure aimed at sampling both the nodule and the pulmonary artery. And we started with the guided bronchoscopy for the diagnosis of the nodule, for which we used a thin bronchoscope, and as imaging guides, we used fluoroscopy and radial Ebus. As you can see in this video, the first thing that we did, we advanced the radial Ebus probe and followed it with fluoroscopy into the superior segment of the right lower lobe. As you can see, we clearly identified the lesion. And once we did this, we removed the Ebus probe and we replaced it with the needle, 21 gauge needle. We did a few needle aspirates and submitted the material for rapid on-site evaluation. Alessandra Cancellieri, who is our pathologist, confirmed that the nodule was not malignant. And yet we decided to do some transbronchial biopsy to complete the procedure and to be more sure on histology grounds of the absence of malignancy. And this is one of the transbronchial biopsies. At that point, we decided to go for the study and the sampling of the right pulmonary artery. As you can see in this video, the pulmonary artery obstruction could be easily identified and studied by putting the ultrasound probe against the anterior aspect of the right main stem bronchus. As you can see, there's no vessel flow. The right pulmonary artery is completely obstructed by this non-homogeneous material. And the other characteristic of this obstruction is that it tends not to infiltrate the vessel wall. As you can see here, the margins of the pulmonary artery wall are clearly identifiable, and there's not sign of infiltration. After the study of the lesion, we went for the fine needle biopsy. As you can see, the needle could be brought very easily into the pulmonary artery. As you can see, again, the needle is very well visualized. The needle back and forth movement can be performed very safely. And once again, we did 4 needle passes with suction. At rapid on-site evaluation of the first needle pass, we could already identify several tight aggregates of neoplastic spindle cells, which strengthened the suspect of sarcoma. At higher power, besides the spindle cell and the pleomorphic aspects, we could also identify some mitotic figures, such as the one identified with the red arrow, which are rarely identified on cytology grounds. But what is more, once again, this is what you get with these needles. You get very large tissue cores. As we did for the case of lymphoma, we expelled the tissue cores from the needle with the stylet, and then we retrieved it from the slide with the needle and put them into formalin solution. And once again, these are the fantastic tissue cores that you get, very cellular, perfect morphology. As you can see in this high power image, in the left side and the right side, you can identify, as shown by the green arrow, the spindle cells. You can identify the pleomorphic aspects identified with the red arrow, and even mitotic figures, such as the one highlighted by the yellow arrow. Interestingly, the transbronchial lung biopsy from the pulmonary nodule showed pulmonary parenchyma effaced with coagulative necrosis of ischemic origin. So in the end, this complex advanced diagnostic procedure allowed us to diagnose a pulmonary infarction of the superior segment of the right lower lobe and an intimal sarcoma of the right pulmonary artery, thanks to this tissue core, which could be submitted to a large immunohistochemistry panel, which you can see at the top of this slide. The patient is currently undergoing induction chemotherapy in view of the pneumonectomy and the pulmonary artery resection and reconstruction. The last case I'd like to share with you is a simple case, but on a difficult topic, which is lung cancer. In particular, I want to focus on what we know on the ability of Ebus FNA to completely profile lung cancer. As shown in the poll, there are people who cannot get a very high success rate of molecular profiling with FNA needles, and this is not uncommon. The problem is that the guidelines cannot come up with a standardization of the technique and of the management of the sample, because basically it is more useful to discuss in each center with pathologists and molecular pathologists and set up a management algorithm that fits that specific center. What we do in Rome is when we do an Ibustivini procedure for a patient with advanced lung cancer, we do the first needle pass with no suction, and this material is smeared on 4 or 6 slides, a couple of which are submitted to rapid on-site evaluation. If the pathologist confirms the presence of malignancy, all the subsequent needle passes are performed with suction with the aim of retrieve tissue cores or at least to prepare a cell block. The reason why tissue core or cell blocks are very important, as highlighted by every guideline regarding Ebus, is that Some specific studies, such as immunohistochemistry or PD-L1 testing, are reliable only on paraffin or on formalin-fixed paraffin-embedded material, such as the cell block. The problem is that the cell block, as shown by the literature, can be inadequate for molecular testing in a percentage of cases in real life ranging from 20 to 60%. And this survey from the American Pathology Society shows how the pathologists are unsatisfied from their cell blocks in approximately 35% of the cases, mostly because of low cellularity. This is the reason why, besides doing cell block, which is one thing that we do always with our procedures, we prepare from the first needle pass some smears, which are very simple, not time consuming for lab. The quality of the DNA contained in these smears is optimal because they are fixed in the alcohol solution, which has not a negative effect on the DNA. If you apply rows to these smears, you know the sample that you get. And if you submit these smears, extracted the DNA from these smears to next generation sequencing, you need a lower amount of the DNA. Several studies, and this is one of them, have clearly demonstrated that if you sample a lesion with the Ibustivini and from the same lesion prepare a cell block and a smear, you will find in the smear much more DNA, and the smear will have a higher success rate for next generation sequencing. So in the end, my suggestion when using Ibustivini with FNA needles is to always prepare a cell block, but diversify the management of the sample by producing also a few slides, and obviously, whenever it is possible, to get a tissue core. And this leads us to our case. The case I like to present is a case of a 57-year-old male, heavy smoker, who seeks medical attention for a single episode of hemoptysis. He undergoes a chest X-ray and then a whole body CT, which shows a mass of the right lower lobe, discretely enlarged ipsilateral, hilar, and mediastinal lymph nodes, and a nodular enlargement of the right adrenal gland suspect for metastasis. The PET scan confirms this by showing a marked uptake in all of the above lesions, and therefore suggesting stage 4 disease. The patient is submitted in another center to an Ebus FNA, which allows to diagnose pulmonary adenocarcinoma and allows to test the EGFR gene, but other molecular tests are unfeasible for pure tumor cell enrichment in the cell block. So the patient is sent back to us for a procedure. This is the CT, which shows, as you can see, the mass of the right lower lobe, the slightly enlarged ipsilateral, hilar, and mediastinal lymph nodes, and highlighted by the red arrow, the metastatic involvement of the right adrenal. We decided to approach this patient directly with an FNB needle, and after evaluating all the lymph node stations involved, we chose the station 7, where we found this relatively large lymph node with dishomogeneous echogenicity and a few calcifications, very small calcification. As you can see, the needle was brought into the lymph node. Once again, see the clear visualization of the needle, and especially of the needle tip. And we did only 3 needle samples because we got a ton of material. This is what we got with one single needle pass. As you can see with the stylet, we bring out of the needle the tissue core, which was very large and very long. So with 3 needle passes, we felt satisfied. These, once again, at low power are the several tissue cores that we got. Going at higher power, once again, you see how well preserved the tissue is and how well the morphology can be evaluated by the pathologist. And in fact, at high power, the neoplastic cell clearly show large nuclei with prominent nucleoli. And sometimes, as highlighted by the green arrow, intranuclear inclusions, which are highly suggestive for adenocarcinoma. Thanks to this tissue course, we could confirm the diagnosis of adenocarcinoma, but above all, could complete the molecular profiling, which was negative as far as genotyping is concerned, but showed a very high tumor proportion score for PD-L1, which was 70%, and led our oncologists to start treating the patients with first-line immunotherapy, and in particular with pembrolizumab. So at the end of the day, my current experience with the Francine cut Medi-Globe needles shows a very high consistency in obtaining tissue cores, which are a very good quality and quantity, and seem to overcome the FNA needles when these needles cannot provide you the answer that you're looking for. And last but not least, they are affordable as compared to many other needles. Currently, our algorithm for using these needles is highlighted in this slide. We basically use this needle upfront whenever we have the suspect of a histological complex condition, such as lymphoma or sarcoma, or when we need to enroll patients into clinical trials where cell blocks are usually not accepted because tissue cores are needed. But we are doing more and more procedures on patients sent from other centers in which an Ebus FNA initial procedure had failed. This happens usually in case of malignancy, for malignancies in which you need an extensive immunohistochemistry study or an extensive molecular profiling, and less common in cases of sarcoidosis where the Ebus FNA attempt has failed, mostly because of the presence of fibrotic lymph nodes. This was my last slide. I thank you very much for your attention, and I open for any question. Thank you.
Yes, thank you, Professor Trisolini. It was a very interesting lecture here. I'd just like to remind the audience that you have on the button here at Zoom the Q&A part, so please feel free to type in your questions. I'm not sure if we can answer everything because we have to look at the time, but Rocco, I have already some questions here. The first one is, any precautions you take to minimize blood in your sample?
I have to say that with the FNB needles, I have not seen a lot of blood. The thing that I've seen that when we get this tissue core, the liquid remaining on the slide is blood, but this does not influence the quality of the core. Maybe the quality of the cytology is a little worse than that of FNA needles, but the quality of the cores is much better. So it's difficult to say how to prevent a blood contamination of the sample. You can usually try and look with the power Doppler to avoid very vascularized lymph nodes or very vascularized areas of your target lesion. But then with the FNB needles, what you want more is the core, is not a good cytology. So for the experience I have right now, the blood contamination of tissue core is not a problem.
Okay, thank you. There's a few more questions. What's your success to have adequate samples for all markers using forceps biopsy and complication? Training need to use these needles? Well, with FNA needle, we have an incredible high success for genotyping because, as I told you in the presentation, we try to do next generation sequencing panel on the slides. The problem is the cell blocks. With FNA needles, we have a failure rate of the cell blocks for PD-L1 testing, which ranges from 10 to 20%. Whereas with FNB needles, our failure rate is basically zero, because when there's cancer in the lymph nodes, with these needles, you always get tissue which is sufficient for PD-L1 testing. So again, this is the perfect answer for a complete genotyping and even for immunohistochemistry large panels, because these needles allow you to do so, unlike what you have with FNA needles. Another question here is, using fanning technique found to increase the yield of the diagnostic in Ebus? I do that sometimes with FNA needles. I have not found this useful with the FNB needles. With the FNB needles, fanning does not influence, in my experience, the success rate of Ibustivini. With the FNA needles, especially when there are large dishomogeneous nodes,
fanning has been able to increase my diagnostic success.
Thank you. Another question, how to prevent bronchial epithelium contamination?
The best thing to do is try to do the Ebus FNA or FNB as the first procedure. This is the reason why whenever we can, when we have basically other procedures to do, such as BAL or bronchial washing or lung biopsies, we tend to do these procedures after the Ebus FNA or FNB. That is, doing a BAL or a bronchial washing may lead to a lot of contamination, even of the Ebus FNA or FNB sample. So my suggestion is to do first the Ebus procedure and then all the other sampling procedures.
Okay, thank you. How to minimize air interference during the procedure?
Which kind of interference?
Air interference on the echo.
Okay. Sometimes we fill the balloon. Using a balloon to have a better coupling of the ultrasound probe with the wall allows us to avoid the air interference, which sometimes you can find with the Ebuscopes.
Another interesting question here, Rocco. Did you perform any special precautions in the pulmonary artery case?
This is the third pulmonary artery biopsy that I do in my career. In this quite uncommon. The suggestion that I do is that when you do this procedure, the needle needs to enter perpendicular to the lesion. Usually, these are not risky procedure when the artery is completely obstructed because there's no blood. It's all cancer. So on average, puncturing these lesions is less dangerous than sampling lymph nodes which have large bronchial arteries in them. The only risk is clearing the artery by not staying perpendicular. So I would enter like this to avoid the risk of rupturing the artery. But the risk of bleeding is very low because when these arteries are completely replaced by the tumor obstructing the artery, the risk of bleeding is very low.
But we need to look a little bit at time. Let's have two more questions before we move on, Ms. Ilya. There's two questions going about cryoprobe. What is your opinion about performing Ebas using a fine cryoprobe to get sample in difficult cases like lymphoma suspected?
I've seen something in the literature, and I was thinking about that. But when I started using the FNB needles, I have to say that I feel less need to use them. That is a procedure which is more complex and especially more costly, because to do a cryoprobe biopsy of the lymph node, you need to use an Ebus 19 gauge needle, which is quite costly, to the hole into the respiratory mucosa. And then you have to use the cryoprobe, and the single-use cryoprobe is quite costly. So I would go first with Ebus FNB, and then if not diagnostic, I might also consider using doing a biopsy of the lymph node with a cryoprobe.
Okay, last very interesting question is, are bleeding risks increased with using Ebas FNB needles in the procedure?
That was my fear when I started using these needles, but for the time being, I have not seen any significant bleeding. So what I would say, concluding my talk and my answers, is do not trust me. You trust yourself, try the needles, and then you'll see by yourself if these needles are good or not. In my career, I've been promised wonders by all the needles that have come into the market, and most of them have disappointed me. So you don't trust me, you just try the needles.
Okay, so again, you have to look on time, but thank you, Rocco. It was a very interesting speech. There's much more question. You're still online and you will use the chat function, and I hope you can answer most of it. But thank you again for supporting that event. It was great. And now, yeah, we have to move on, and I'm really excited now to announce the next person. It's Ilya Sivokosov. Hi, Ilya. Again, a pleasure to have you here. And again, as well on your side, we will start with a poll. Heike, could you share that with us again, please? Thank you very much. So the question is, in case of suspect stage 2 sarcoidosis, which diagnostic modality do you currently use most? You can have multiple answers here.
Yeah, you can choose up to 3 answers, I think, colleagues. So thank you, Martin, for the invitation and kind introduction. And I think it would be really interesting what the answers would be on the webinar dedicated to the Ebus. I don't know who will choose what answer, but probably the Ebus will be one of the main, one of the mostly chosen variants.
Yeah, we still keep it 20 seconds open, but yes, you're right. The first one is 87%.
This is quite logical. Yeah, this is quite logical for the type of our webinar. But I think that also some other variants are in the field.
Number 2 is the second one. It's ball. And then the rest is quite equal.
So can we see the results? How do?
Yes.
Yeah. Yeah, that's really interesting because it's not surprising that the Ebus or EUS will be the #1 in a webinar dedicated to the Ebus procedures, and the second place the BL and then transbronchial lung biopsy. And 1 out of 10 of our participants mostly use transbronchial cryobiopsy. That's really interesting. Rocco, would you comment on this, or we'll just proceed with the lecture?
Go ahead, Ilya. We'll comment later.
Okay. Okay.
Let's see the talk.
Okay. So I think that can I go to the presentation now?
Yes, please. It's your stage, Ilya.
Okay, thank you so much. I'll just try to show my screen. Just a couple of seconds. Sorry. Can you see my screen now, or?
Not yet, Ilya.
Not yet, okay. I'll try to do all my best.
We can see you now. Yeah, video.
Yeah, I see. So I will share my screen, and then I'll go up with the presentation.
It comes.
Yeah, the presentation is open now, yeah?
Yes, we can see it now.
Okay. Well, thanks again for the invitation for such a nice webinar. I was really deeply impressed by the quality of presentation of Professor Trisolini, especially some new data and tips and tricks doing the F&Bs. So now we will move on from lung cancer area to the granulomatous disorders. And I think this would be also quite interesting for us to move on through the benign diseases. So I will not answer the, I will not render the conflict of interest dedicated to the exact several options, but you got to know that I have a huge co-interactions with different companies. But anyway, when we talk about the diagnostics of sarcoidosis, we always talk about several different types of biopsies. These are magnificent 6, so I would say. I'll just show them, yeah. So the first one is the bronchial velar lavage, then the endobronchial biopsy is going in, then the transbronch, then a cryo, Ebus, and a conventional TB&A. Now we'll move on through several of these biopsies and just shortly describe the variants of the possible biopsies which can be used. So the bronchial velar lavage itself, as you can see here, this is a flushing of the peripheral part of the tracheobronchial tree with a saline. So this is a really controversial area in diagnosing of sarcoidosis because of several reasons. Cellular pattern is not specific enough to establish a diagnosis, and subtyping of CD4 to CD8 and immunology is not used routinely. And it is stated in international guidelines that it is insufficient method to diagnose the specific type of any ILD, also not sarcoidosis, but all the rest, if it is used alone. But in several situations, this can overweight the decision of clinician in several directions. So what are the positive things of bronchial velar lavage? It's cheap, fast, and safe. This is the best media to culture and PCR for infection, mainly for tuberculosis exclusion. And the negative things that it's not enough specific, and normal cell count does not exclude ILD. So the endobronchial biopsy in sarcoidosis, I think that the Rocco now will smile because this is actually one of our studies dedicated to the endobronchial biopsy in sarcoidosis. If you don't see any abnormality, you still need to do the 6 specimens from different parts. They're listed on the slide. If you see some endobronchial abnormality and suspected endobronchial sarcoidosis, you got to do the 4 specimens from area of interest and 2 more biopsy specimens from contralateral carina. So what are the positive things? The good news are that if you see something suspect on the bronchial mucosa, then your diagnostic yield will be really high, more than 90%, and it's really safe. But the bad news, the bad side of the coin is that if you don't see anything on the bronchial mucosa, then probably your diagnostic yield will drop lower than 40%, and the bleeding is still occurring. So the transbronchial lung biopsy is also shown on the video. So the TBLB can be performed with fluoroscopy or without. You can do this even without fluoroscopy. It can be done under local and general anesthesia. Usually do 3 to 5 specimens, mostly right middle lobe. Larger phosphorus will give you a better yield. So the average yield of transbronchial lung biopsy is 2 out of 3 patients. So this is around 70% in case if you have the patient with a stage 2 or 3 sarcoidosis. It is safer than cryobiopsy, but you got to pay for that with a high rate of pneumothoraxes. So the pneumothorax rate during the EBB and bronchial velar lavage is 0, almost 0, I think. And the bleeding rate is around 7%. And we talk about transbronchial cryobiopsy, and you see there is a huge specimen. So the transbronchial cryobiopsy can be performed only with guidance. You need some kind of a guidance. It could be fluoroscopy, it could be radial Ebus, whatever. It is recommended to be done under general anesthesia, and regional bronchoscopy is preferred, and the foggity balloon to stop bleeding because sometimes the bleeding can occur. And usually we take around 3 to 5 specimens, and mostly right middle lobe and right lower lobe. So the cryobiopsy now has a really high yield. It's around 70 to 89%, and this is the best tissue from the pulmonary tissue it is. The negative part is that the pneumothorax rates can be really higher. It's around 15%. It could be more than 15%. And the bleeding rate is much higher than transbronch and bronchial velar lavage. So now we move on to the Ebus in sarcoidosis. Is it a game changer? Well, so the Ebuscope can be inserted through the trachea, and this would be Ibustivini procedure. It can be inserted through esophagus, and this would be USB FNA procedure. It can be performed both under local, but currently we move on from the local, but still you can use it under local anesthesia, especially if it's transesophageal way. You can use it under sedation or general, usually 3 to 4 passes, and mostly we take a biopsy from subcarinal lymphatic nodes. So the yield is up to 95%. It is really safe, but the negative part is some tips and tricks with the tissue processing and the cost of equipment, especially when we compare it to the conventional transbronch and BAL. So you see here, sorry for that, this is Hitachi Oloka with a Pentexscope, but the needle is the same. This is F&B from Medi-Globe. So what the current guidelines in diagnosis and treatment of sarcoidosis stated about endosonography. The last guidelines, which were before the 2008, 2020, they were issued in 1999, just even before then Ebus revolution started. So there was nothing mentioned there about Ebus. The last guidelines, which were issued last year in 2020 by the American Thoracic Society, they have some statements dedicated to this approach. And the first statement is really interesting. In patients, when the clinicians looks at the patient with a suspected sarcoidosis, if you have a high clinical suspicion for sarcoidosis, it is suggested not to sample in the lymphatic node. So if the patient is coming with Lofgren syndrome, Hereford syndrome, or for example, some types of it, yeah, even some parts of it, like erythema nodosum without any fever, you still cannot sample the lymphatic nodes because the probability of sarcoidosis in these patients is really high. But what about the situation where the patient is asymptomatic and he or she still has bilateral lymphadenopathy? So the recommendations doesn't say nothing about that. So this is a really interesting part. So you got to make your decision, and this is the third part of it. So for patients with suspected sarcoidosis, when the tissue sampling is necessary, Ebus is recommended over all the other techniques compared to the sampling of lymphatic nodes. I mean, meta-acinoscopy or conventional TBNA. So what do we do in our clinic before we start? You see here the initial setup, the needle for this day. This is a Medi-Globe. So the smear slides on the bottom. On the right side, you see multiple needles just to look, just to handle the biopsy specimens, the formalin vial, which is definitely closed, the bite stick, the vacuum syringe, and so on and so forth. So what do we do just before we start? We got to check the needle for its integrity, which we got to check all the knobs, lower knob, upper knob, to look that the needle is going in and going out, that the stylet is working smoothly and proficiently. So we got to know that the needle is fully set up before the biopsy will start. So secondly, when we perform the vacuum aspiration, how it goes, you see here that there's always a double check, both from the nurse and from the bronchiologist. Currently, this is an USB procedure performed. Sorry for that, this is quite old machine. This is EU IMU1 from Olympus, and this is the scope, which does around 700 biopsies with this scope. So now you see that we're trying to find the path to the lymphatic node, and we're sticking in with a needle. And now we have thrown the stylet. The vacuum syringe is going in. We open the vacuum, and now we're starting the movements. It's a good question, how many agitations you got to do to achieve the best results. So there is some finding technique just to change the trajectory of the needle. And so now the aspiration is closed. It's going out. And now we're ready to go out with the needle. Also, we can use a capillary technique, which was definitely better in the type of cytology, I think, but I think that we can discuss it later. And now you see again that now we try to perform the same with the same patient. We're performing the biopsy in the subcarinal lymph node, and you see here now we're trying to find a path, and the sometimes it's not really simple to find a path through the vessels. Now we'll try to use a Doppler just to find where the most safe way for the needle existing, because now we'll try to use again the Doppler, and you see there is a full river of large vessels. So we're not trying to penetrate these vessels, especially when we use an F&B needle. So anyway, you're always trying to find the way, because the endosonography will give you such a brilliant possibility to look where the vessels are, and now we can puncture. So the puncture is going in. Oh, we're almost there. Yeah, we're in, and you see that the tip is in the needle, is in the lesion, in the lymphatic node. And now the pulling technique is starting. Slow pull of the stylet out. So we're creating a really small negative pressure just to retrieve the best cytology specimens. So when you use a cytology specimen, watch out of bloody mess. That's why we're always trying to use the next, another smear slide just to save us from the blood mess. And then the gentle movements just to prepare the slide with a one movement, and this is okay for the cytology. And the moment of truth at tissue core, we don't use ordinary, so to say, a needle technique. We don't use a slide to prepare the tissue core. We use a formalin, like a cell block, so to say. So this is quite okay to establish the good quality tissue. And last but not the least, don't forget to perform, we always perform PCR and culture for tuberculosis and different other infections, especially due to a high burden of tuberculosis in our country. That depends on the country you live in, because in some countries, the spectrum of infections would be quite different. It could be fungal infection, parasites, and so on. So quality of F&B needle, impact of aspiration. So just looking to the left slide and to the right slide. On the left part, On this slide, you can see the picture after the capillary technique, much more higher load of cells. And on the right slide, you mostly see the blood. So that depends on the quality. So the quality of specimen you retrieve will depend on the suction power you apply. So is it really working, the smear cytology or core? What is better? There are several studies dedicated to this question. So on the left, you can see the smear. On the right, you can see the core. What is better? And our colleagues from Poland did a study last year dedicated to this question. And you can see here that the Ebus and Ebus, according to the smear cytology, they have almost the same. They have almost the same diagnostic yield. I'll just try to use it. Yeah. So for the smears, the efficacy of granuloma detection rate is around 50% for both Ebus and Ebus. But when we combine two of these approaches, so we go transesophageal and transbronchially, the yield will be higher. I know that the Roku knows this publication because he was an author of editorial letter to this issue of the Polish Scientific Journal. But when we look about the smear and a cell block combined, the diagnostic yield is higher when we combine two of these techniques, both of them, both cytology and cytopathology specimens, the yield going up again to 72 and 66% and up to 86%. But interestingly, when the authors compared for both procedures, the efficacy of granuloma detection rate for smear and for the cell block, the smear is still better in detection granulomas than cell block, which is really interesting. So in 2013, a great study was published. It has some limitation, but still the granulomas randomized clinical trial is one of the largest randomized trials dedicated to the question, which is better in diagnostics of sarcoidosis, conventional transbronchial lung biopsy plus BL or endosonography. The interesting result was shown during this study. The granuloma detection rate with Ibustivini was only 66%, and with EUSB or EUSFNA, it was much higher, and the difference was statistically significant, almost 90%. Why was it done like this? I think that we can discuss it later. So does the needle type impact on Ibustivini efficacy sarcoidosis? So on the left, you can see the really FNA needle, and on the right, you can see the corona-shaped F&B needle. And the answer is probably yes. There was a nice study by Huria and colleagues, and this study was dedicated to direct comparison, randomized trial where around 100 patients were randomized to two groups, one group with F&B and another group to FNA. And you see that the granuloma detection rate was 74 and 86. It was larger and a higher yield using F&B needle, but still these results were statistically non-significant, and the authors came to the conclusion that we need more sample size just to make these results more statistically significant. So, okay, now let's move on with our local and still sadly unpublished data. Till this year, we have 313 patients with sarcoidosis diagnosed with final diagnosis of sarcoidosis who undergone Ebus or EUSB. And you see that our results showing that FNA and FNB has almost equal diagnostic yield, but still probably the FNB is better than FNA, but again, this is 0.007. What is the axis? The axis of EUSB is even higher than Ebus, but still again, we don't have statistically significant results in this comparison. The interesting thing is that the smear granuloma detection rate in our clinic is lower than the cell block. And this difference is statistically significant. So still, the cell block is better than a smear alone, in our clinic at least, in detection granulomas and sarcoidosis. So now let's move on to the suspected, to several cases discussion. So the case one is a suspected mediastinal recurrence in patients with a colorectal cancer. So the patient, 3 years before admittance to our clinic, he has a surgery due to colorectal cancer with chemotherapy subsequent. And during the normal and conventional follow-up, the PET-CT showed a small tiny nodule in the subcoronal area, which was PET positive. So the oncologist decided to perform an Ibustivini, and so it failed to show anything. No cells of lymphatic node, no cells of anything like malignancy or something like this. So we decided to use EBUS-FNA, but at this type, we decided to compare directly head-to-head, compare the FNA and FNB needle from Medi-Globe. Of course, patient was informed about that. There was a formal informed consent form signed, and the local ethics committee approved this. So what did we see? Again, as Rocco, we also use an Ariad 850. This is a brilliant ultrasound processor, and you can see here, this is not so huge lymphatic node. And according to the color Doppler, there are some small, tiny vessels inside it, but mostly this is a fibrotic, and probably this is an area of fibrosis, which is not surprising due to the previous chemotherapy. So according to the sonal elastography, it was a mixture of green and blue pattern. So I would say this is a, according to classification of Japanese classification, this is mostly type 2. So what did we do? We tried to do all of our best just to perform a biopsy. On the left, you see the, and on the left, you see the, I'll just take out the, just a moment. On the left, you see the conventional FNA needle from Medi-Globe, and now it will penetrate the lymphatic node. Yes, so we're in, the diastolic goes out, and we apply suction. So this is a, we use the same suction syringe. This is a 10 cc suction. So on the right, you can see the same lymph node, but a bit larger magnification, and this is an FNB needle. And also we use a stylet and a suction, and to some extent we used also a fanning technique. So now you see that the aspiration started and the movements also started. And so what did we retrieve after that? Let's look again on the left slide. On the left view, you see the specimen which is retrieved directly to the formalin from FNA. And it's a nice looking core, but let's look on the right. And you see it a bit more blood, but there's a higher amount of tissue, much higher amount of tissue. Probably this will be a more bloody, but still the amount of tissue is much higher than in FNA needle. And now let's move on to the pathology. Right? So the pathology, lower magnification around 50, and you see there is a lot of pores filling with blood, but still we see here several granulomas, and this is 22 gauge Proflex. On the right side, we see a well differentiated and shaped granulomas. A bit more granulomas were detected in these specimens by our pathologist, Professor Simonova. Now you can look at the larger magnification, and you see they're almost equal, but the quality of granulomas on F and B was a bit better. But still, when we asked our pathologist, are these specimens both suitable for the diagnosis of granulomatosis in lymphatic node? She said, yes, definitely it is. Well, we didn't find anything with suspected tuberculosis infection or any other types of infections. So the final diagnosis for this patient was sarcoid-like reaction, which is definitely a good prognosis for him. So in other cases, a suspected sarcoidosis stage 2 after coronavirus. So this is a young 32 years old male who suffered from coronavirus, survived it, and in a couple of months after his disease, you can see here on the right lung in a middle lobe, on the upper lobe, you can see here a small, tiny ground glass opacities, but also some tiny granulomas. some tiny dissemination, and a huge subchoroidal and hilar lymphadenopathy. So what we decided to do, we decided to firstly just this patient was referred to another clinic with a conventional bronchoscopy. So the patient was referred for BL and transbronchial lung biopsy, and nothing was revealed. Then we decided to perform an Ibustivini, and sorry for that. This is a Fuji scope actually, but due to the opening of channel, working channel for the Olympus and Fuji scope, they are almost equal. So I can say that this is some kind of Olympus scope. So you see here, this is elastography, and you see that the one of lymphatic nodes is more soft, another one is a more rigid, and we can perform a biopsy. And you see here, there is a trace, and the needle is moving just in a subchoroidal area, and we also can use it with a bit of fanning technique. So what did we retrieve again? On the left part of it, this is an FNA Proflex in the same patient, 2 passes with Proflex, 2 passes with a top gain. And again, what we see here on the lower magnification, we see here that there's again a lot of blood, but still we have some granulomas. But on the right side, we see a real tissue course. This is looking like this. So this is a real tissue core with a full set of granulomas. So according to our pathologist report, the second biopsy, the biopsy number 2, she didn't know about the exact type of the needle which was used. She said that these results are more definitive to establish a diagnosis because the granulomas are looking just the same as they are looking on the surgical specimens. So the diagnosis of sarcoidosis was established, and the patient is under surveillance now, so the systemic therapy with oral steroids was not started. So last but not the least, we should not forget about the tuberculosis. In different countries, the impact of this disease on everyday life is different. In South and Eastern Asia, in Russia, in Africa, there is a lot of countries with a high burden of tuberculosis. In the United States and in the Western Europe, the prevalence and incidence is much lower. But we always need to think about it because still tuberculosis is a #1 infectious disease and #1 killer. And this is the case of a patient, a female, 55 years old woman. She was admitted to an oncology clinic with suspected right upper lobe lung cancer, and she was actually referred for the surgery. But before the surgery itself, the biopsy was decided to be done, and then the oncologist directly discharged the patient to our clinic, a Central Tibet Research Institute, because of this. So you can see this is Olympus 190, a really brilliant image, but you see there is a total necrotic areas, infiltration and necrosis on the anterior part of trachea. Almost all the rings are covered, and you can imagine that this patient has a severe cough with a huge sputum production. And you can see here, this is nicely shown in an NBI image that the necrotic area is almost half of trachea. So anyway, the diagnosis in this case was established easily. Not so easily as it can be imagined. You need to go out, you need to uncover the real surface and make it free from, you need to remove necrotic tissues first, and only then, after that, you will establish the diagnosis due to cytopathology and microbiology, because the most important thing for these patients is the drug susceptibility testing, because we know that this is tuberculosis, but we got to know what treatment you should prescribe. So for this patient, it was a happy situation. This was a wild type TB without any resistance. So Ebus and tuberculosis, is it really effective? Or you know the proverb that the tissue is the issue for the tuberculosis, the culture is the issue. If you know that this is a necrotizing granulomas are found inside the lymphatic node, you still need to understand what the disease lies behind it. What's the situation? Is it a granulomatosis due to tuberculosis, or it could be non-tuberculosis mycobacteriosis, or it could be a fungal infection, and so on and so on. So this is a typical picture you can see in a patient with suspected tuberculosis. In one part of the lymphatic node, you can find an area of more fibrotic tissue with some calcifications, and here you can definitely some necrotic areas. So what is the yield of different methods when we use an Ebus in several populations? There are, I tried to find the latest studies, so to say, the most fresh studies from 2021. And one of the studies was done by our colleagues in India, a high burden of tuberculosis. Another one was done on refugees in Western Europe, the refugees mostly from Somalia, from Africa. But you see that the detection rate of necrotizing granuloma is almost 91% in one study and 67% in another. It's still 2 out of 3 and almost 9 to 10. But the acid-fast bacilli detection is much lower. The PCR is also much lower, and the culture is less than 50%. And the most important thing for these patients is the culture results, because you got to know the resistance profile. You got to know how to treat the patient. If you know that this is a tuberculosis, okay, it's good. You have a confirmation with a gene expert or something like this, and probably you know that this is isoniazide or rifampicin resistance due to biochips, due to PCRs. But you don't know, is it really single resistant, or it is a multi-drug resistant TB or XDR, or still drug sensitive? Because even if the patient has a isoniazide or rifampicin sensitivity, he or she can definitely has a monoresistant to other drugs. So, and if you will see at the meta-analysis for different and multiple studies, you will see a great variety of results due to efficacy of different methods. The old studies stated that the necrotizing granuloma can be detected, but for the clinicians, the most important thing will be culture results. And the efficacy of culture confirmation of tuberculosis is much lower than cytology. So the good example, just to show how it goes with the tuberculosis in our clinic, this is 8 years old child with a suspected TB. You can see here, this is a young woman, so to say, 8 years. And she has different calcifications inside the lymphatic nodes, and some of your relatives was infected with tuberculosis, and this tuberculosis was unknown again. The confirmation was not retrieved. So the main indication for us was to use an USB or Ibustivini endosonography just to confirm the diagnosis. And you see here, again, area 850, and this is a lymphatic node in mediastinal, in subcarinal area, and you see here a huge hyperechoic area which resembles the fibrotic and to some extent even calcifications. So anyway, we performed a biopsy with F&B needle, for sure under general anesthesia, and retrieve a nice course. And thanks God for this situation, we retrieved a good pathology specimens like this. And in one of these specimens here, our pathologist found the necrotic areas and pigmented areas. And PCR, the most importantly, the PCR and the culture were both positive, and the PCR showed that this is a Mycobacterium tuberculosis, and this is a drug-sensitive TB due to culture. Well, my feedback, my own feedback about of marketing, what can I say about the positive and negative things, so to say, about the needles, F&B needles. So the F&B needles from Medi-Globe are really sharp. So that means that the penetration force is really high. The cellularity and the tissue pores are really, really more often retrieved. But there is always another part, another side of the coin. You always need to obey the rules. You always need to use a stylet. You always need to look at the instruction what the exact your step should be. And probably we can retrieve more bloody specimens using FNB. Up to our experience now, I see yes, in granulomatous disorders, at least in my experience and our experience with our cytopathologist, I would say that probably yeah. But I think that the more bloody specimens, this is not a problem at all, because your pathologist can wipe it out during the processing of the specimens. And this would be quite okay if you will have still tissue in it. Well, thanks for your attention. And can we go to the final voting?
Yeah, Ilya, let's
Okay.
have the, Heike, can you display the poll?
Yep.
Thank you. Can you see it, Ilya?
No, I can see. Can I comment on it just to save your brain or not? So the question is, what do you consider the main method for confirmation of sarcoidosis in your specimens during the Ebus and EOS? So this is smear cytology alone. It is enough for detection of granulomas. Another one is a liquid-based cytology. We didn't talk about this much today, but I think that this would be a good question to discuss. The pathology confirmation is preferable, even if cytology contains granulomas, even if. And the only pathology cores are analyzed because cytology smears are almost not prepared. We know that the several clinics don't believe in that, or pathologists that don't believe in that. And so the last but not the least, both cytology and pathology are valid methods. So Martin, would you comment on that about the process of voting?
We have the last one is 59% and followed by the the third one with 26%, but still voting the people. Let's
Okay.
give them another 10 seconds.
Okay.
But definitely last one, both cytology and pathology are valid methods. 59%.
So do we have believers and non-believers in cytology?
Okay, I think we can close.
Can we see the results?
Yes.
Yeah, it's really interesting that almost 2/3 of the audience believe in both cytology and pathology. But again, the pathology preferable of around a third of the audience are believers mostly in pathology specimens. That's really interesting. Martin?
Yeah, thank you, Ilya. I think, I mean, I don't know, lucky or unlucky, Rocco was very busy answering a lot of questions, but he's also here. I have two more to share here. In which conditions you prefer FNA needles instead of FNB?
In which conditions you prefer FNA needles instead of FNB? Actually, I would say that if the patient is coming with a fresh sarcoidosis, with a fresh suspected sarcoidosis, no signs of fibrotic areas in the lymphatic nodes, I would probably prefer to use an FNA needle. But again, in any situation where I don't have any huge suspected lymphoma or something which will definitely need a tissue diagnosis, yeah, I would still have an option to use an FNA. But again, if you will start an FNB procedures, you will be more and more involved into the pathology reports, and you will be more and more, so to say, addicted to the pathology in your everyday routine. So I think that in a typical classical situations with a suspected sarcoidosis, you can use both of them. And I have shown you that in both of our clinical cases, granulomas were found. But again, in any case of fibrotic disease, the FNB would be more effective.
There's another interesting question. As a lesion is near to the chest surface, why you people can't try use USG guided or CT guided biopsy in the 8-year-old child or 8-year-old child?
Yeah, that's really interesting. So the most important thing was that in our clinic, for example, we don't perform a CT guided biopsy in a pediatric population. So, and the most important thing was that the main area was for our pediatrician, the main area was subchoroidal lymphatic node. So we did a more safe procedure, I think, because a transferesis guided biopsy in a child, I think that it's It's more aggressive than when you perform a biopsy through esophagus, because we started from 2 years old. We can perform it from starting from 2 years old. So from my answer, in our clinic, we don't currently perform CT guided biopsy in a patients younger than 18 years old. And the second is that it's completely much more safe to do the biopsy.
Okay, thank you. Maybe looking at the time, let's have 2 more questions before we come to the closing. What is the yield Ebus in lymphoma?
Well, can we address this question to the Rocco, I think?
The diagnostic success, the average diagnostic yield in lymphoma depends, again, on what you consider diagnostic. If you consider diagnostic a generic diagnosis of lymphoma, then the diagnostic yield is 70 to 80%. But if you want to subtype the lymphoma on the Ebus FNA specimen, then the yield drops by far below 40%. This is with FNA needles. Now we are in the process of checking whether if with the FNB needles, this diagnostic success can increase, especially in the disease subtyping. The problem with lymphoma is that many lymphomas have a huge inflammatory background and few neoplastic cells. So you need large samples, which FNA needles do not provide you. So we will see if FNB needles allow you to increase the number of neoplastic cells that you find, besides a good preservation of the histology tissue, and allow you to do extensive immunohistochemistry, which is required to subtype the disease.
Thank you, Rocco. Last one, again, you are in the chat, Ilya, and you will stay in this chat for some more minutes, but this one, great masterclass. Thank you very much for that. While doing Ebas, can you differentiate lymphoma, TB, sarcoidosis per OP? I mean hardness of lymph nodes.
Yeah, I see. Well, actually, I can say that sometimes you see on the lymphatic node and it's really hard and you make a biopsy and there are some granulomas. And the other time, the patient is coming with a soft lymphatic nodes and this is a non-Hodgkin's disease. So, Rocco, would you comment on it?
It's when I'm approaching a patient with sarcoidosis, I have 2 ways to assess whether or not the lymph node is a fibrotic node. One is simply sticking the needle into the lymph node, and if it's fibrotic, you will see that you find a hard resistance on the movement of the needle, and the needle will push the lymph node, but it will be difficult for you to do the back and forth movement. The most elegant one is doing elastography, which can show you a blue pattern, which is strongly suggestive of a fibrotic lymph node. I published a couple of papers that you can find in PubMed in 2019 and 2020, in which we did the pilot study on the role of elastography to identify fibrotic lymph nodes in sarcoidosis. And once again, a blue pattern is strongly suggestive of a fibrotic lymph node. And in these cases, you will find a lot in cytology and histology, a lot of fibrotic strands and few, if any, granulomas. In those cases, I would try and choose an FNB needle.
Yeah, I'm totally agree with that.
Thank you, Rocco. Thank you, Ilya. I think we need to come to an end. It's still exciting and interesting. I would like to ask you to stay for the other questions in the chat. So, but we have to look a little bit at a time. Thank you very much. It was very exciting. And as at the beginning said by Professor Epithelium and Professor Rush, it's not the end, it's just the beginning. So there is much more to come in the future. And I'm really looking forward to have more events. And of course, you're always welcome to join us and specific endoscopy on air. So what I would like to do last is now, Heike, can you do the last poll, please, just to see how was the whole conference and what was the feedback? So how satisfied was the Ebas masterclass for you? So if you can vote, would be great. Thank you very much. Rocco is already busy typing again, and Ilya, you too.
Yeah.
This is Ilya. This is Ilya.
Yeah.
Oh, sorry. You catch me.
No, go ahead typing. Answer the question. I answered many.
Okay.
We were fast, Rocco, very fast. Okay, give them another 10 seconds, Heike, then we can close this one. Most of you said highly satisfactory, and I've learned really new things. I think we can close that. Heike, thank you very much. Yeah, we can share that here. So again, coming to the end here, if there's any questions, you can see our contact details here. As we said, there is much more to come in the future. We're working already also for EOS on some events, and Rocco, really appreciate. Have a nice time, and Ilya, same to you, to Russia. And then thank you very much and goodbye to the rest of the world. Have a nice evening or morning, different time zones. And I'm really looking forward, Medi-Globe and the rest, to see you again. And Endoscopy on Air also, thank you very much. It was a pleasure. Bye-bye.